GLP-1 medications didn't originate as weight loss solutions. They were developed to treat type 2 diabetes. What began as a quiet medical breakthrough has turned into one of the fastest-moving shifts in modern healthcare. Designed to mimic a natural gut hormone that helps regulate insulin, digestion, and appetite, it changed how medicine viewed obesity itself.
This video is made for educational and informational purposes only.
According to recent surveys, nearly 1 in 5 American adults has already tried a GLP-1 medication, originally developed for diabetes and now widely used for weight management.
That number didn't rise slowly, it surged almost overnight. What began as a quiet medical breakthrough has turned into one of the fastest-moving shifts in modern healthcare, driven not just by doctors' offices, but by apps, ads, and subscription plans promising fast access and discreet delivery. And yet, in the rush to make these drugs widely available, an important question often gets lost. Do patients truly understand what they're starting? GLP-1 medications didn't originate as weight loss solutions. They were developed to treat type 2 diabetes, designed to mimic a natural gut hormone that helps regulate insulin, digestion, and appetite. When researchers noticed patients consistently losing significant weight, far more than with older medications, it changed how medicine viewed obesity itself. According to published clinical research, participants in large trials have shown average weight loss of 15 to over 20% of body weight. Obesity was being treated as a metabolic disease, not a personal failure. That shift mattered, and it still does. But science moves carefully, and markets often do not. As demand skyrocketed, traditional healthcare systems struggled to keep up. Patients faced long wait times, insurance denials, and limited access to obesity specialists. Telehealth stepped into that gap. For many people, it wasn't about shortcuts, it was about access. Telehealth platforms offered speed, privacy, and affordability, especially for those who felt judged or dismissed in traditional settings. For some, it was the first time weight was discussed as a medical issue rather than a moral one. And that matters. Access matters. But access without structure can quietly introduce new risks. Telehealth can remove barriers, yet it can also remove safeguards. Without physical exams, with labs skipped or delayed, and with follow-ups that vary widely by platform, much of the responsibility shifts onto the patient. The medication may be powerful, but the system supporting it can be surprisingly thin. Not all GLP-1 prescriptions are the same, and this is where confusion grows. FDA-approved medications like Wegovy, Ozempic, Zepbound, and Mounjaro are not interchangeable with compounded versions, often offered during shortages or at lower prices. As of this video, the FDA has not approved a generic form of semaglutide. Compounded formulations are not the same thing, even when marketed that way. Potency can vary. The FDA has issued guidance cautioning against certain salt-based compounded formulations. Dosing from vials rather than pre-filled pens may also increase the risk of measurement error. None of this automatically makes compounded medications unsafe, but it does mean they require extra vigilance, something rushed onboarding processes rarely emphasize. GLP-1 drugs are also not appropriate for everyone. People with a history of pancreatitis, gallbladder disease, certain thyroid cancers, severe gastrointestinal disorders, eating disorders, or advanced kidney disease require careful medical evaluation, not just a checklist on an online intake form. This is why working closely with a qualified healthcare provider matters. For the right patients, though, those with obesity, metabolic syndrome, insulin resistance, or persistent food noise that undermines healthy habits, GLP-1 therapy may be significantly beneficial, especially paired with education, strength training, and ongoing monitoring. That monitoring is where real safety lives. Kidney function, liver enzymes, blood glucose, hydration status, and muscle mass trends matter, particularly in the first year. Rapid weight loss doesn't just reduce fat, it can reduce muscle and bone density if protein intake drops and resistance training is absent. Muscle preservation isn't cosmetic, it's essential for long-term metabolic health, mobility, and weight maintenance. Yet many patients are never warned about this until they feel weaker, more fatigued, or stalled. Side effects like nausea and constipation are common and well known. What's discussed less often is dehydration. When appetite and thirst drop together, kidney stress can develop quietly. Gallbladder issues can surface. In susceptible individuals, the pancreas may be irritated. These risks are manageable, but only if they're anticipated and monitored, not ignored. There's also the question few platforms address clearly. What happens when the medication stops? GLP-1s suppress appetite, but they don't permanently rewrite biology. Hunger signals return. Metabolic rate may stay lower. Without a structured exit plan, a significant portion of lost weight can return. Clinical trials account for this with coaching and close follow-up. Real life often doesn't. That's why real-world results frequently fall far short of trial outcomes, not because the drug failed, but because the system around it did. Emerging research continues to show promising benefits beyond weight loss, including reductions in cardiovascular risk and improvements in metabolic markers.
Preliminary and early-stage research suggests possible effects on brain function and mental health, such as reduced food noise and improved insulin signaling, though this area requires further study.
Science is exciting, and the future, possibly with newer multi-agonist drugs, looks powerful, but progress without patience has consequences. Online, the risks multiply. Non-prescription GLP-1 alternatives, oral drops, and peptide products are spreading rapidly.
As a general educational guideline, legitimate GLP-1 medications require a valid prescription. If a product claims to offer the same effects without one, that should raise serious questions.
Many of these products are unapproved, poorly regulated, and sometimes chemically unrelated to real GLP-1 medications. Meanwhile, regulators are increasing scrutiny, and lawsuits over billing practices and safety lapses are already emerging. None of this means GLP-1 telehealth is inherently unsafe. Used thoughtfully, it can expand access and change lives. But the difference between benefit and harm is rarely the drug itself. It's education, monitoring, and continuity of care. Patients who ask the right questions, verify pharmacies, start at appropriate doses, and pair medication with nutrition and strength training put themselves in a far stronger position. GLP-1s can be transformative when used with care, context, and continuity. The danger isn't that these drugs exist. The danger is treating them as simple products instead of powerful medical tools. In a system moving faster than regulation and education can keep up, informed patients aren't just participants, they're essential partners in their own safety.
This video is for educational and informational purposes only and does not constitute medical advice. Always seek the advice of a qualified healthcare provider regarding any medical condition or treatment.